thrilled to introduce this month's speaker, Dr. Scott Ackerman, board certified in radiation oncology and fellow of the American College of Radiology. He's the medical director at Ackerman Cancer Center. After completing his training at Columbia University in New York City, he came to Jacksonville and has been in private practice for more than 30 years, serving an integral force in the Florida's fight against cancer. He held positions as the chief radiation oncology at St. Vincent's Medical Center prior to opening Ackerman Cancer Center in 1997. Clearly a true trailblazer in this space. During his tenure at St. Vincent's Healthcare, he immersed himself in patient advocacy and community awareness. He continues to support these ideas and is a strong believer in individualized patient care. Currently, Dr. Ackerman oversees First Coast Cancer Foundation and serves on the Florida Board of Medicine. We are excited to have you, Dr. Ackerman, and really appreciate you taking time out of your day to talk to us about lung cancer and the importance of getting screened. For those who are not aware, November is Lung Cancer Awareness Month. So thank you, and take it away.
Thank you, Ashley. You all can see my screen, I hope, correct?
We can.
Good. So thank you for having me today. It's an honor to be able to address you all. And I don't think I've ever addressed this group. I've addressed a lot of groups downtown. There's a very interesting group, the Health Council of the Chamber. I've met with some other parts of the Chamber in the past, and I think it's a very interesting and dynamic group, and I'm glad you guys are doing what you're doing. So I'm a radiation oncologist. As you know, as Ashley told you, I originally was at St. Vincent's. I'm still on staff at St. Vincent's. I came to Jacksonville in 1988. I just had my residency at Columbia University and came here in '88 to join the staff of St. Vincent's. I'm on the staff of every hospital in Jacksonville, but the St. Vincent's where I started, and I'm still on the medical staff there, and ran the radiation department there for quite some time. Currently, one of my partners is there. We still run the radiation department at St. Vincent's. But I focus my efforts currently at our two offices, one in our larger office in Mandarin, and that's at the intersection of San Jose and 295, right just north of Walmart. And we also have an office in Amelia Island, where I am today. You can see behind me, you're looking at the beautiful Amelia Island. It was sunny a little while ago, but not so much right now. In our office in Mandarin, what's unique about that office is that we do a proton beam radiation. And many people know about proton beam radiation with the University of Florida. University of Florida is a trailblazer in proton beam radiation, and University of Florida instituted it in 2005. We were about 10 years behind them in incorporating into our practice, and we're very happy to be able to provide the same life-saving treatment. We do a lot of collaborative work with the University of Florida. We're involved in clinical trials and research with them, and also our colleagues at Mayo Clinic are putting in proton therapy as well. They should be live with that in about 3 or 4 years. And we collaborate with them as well. And in fact, they do a lot of research with our proton. They use our proton equipment currently until theirs is up and running to do some of their more scientific and bench research. They basically radiate tumor cells that are in Petri dishes and things like that. The crazy scientists do it at my office at night. They're not so crazy. They're good. They're good people. So we're independent, and we collaborate with. The point is, we do a lot of collaboration around the city. So let's see. My thing isn't. Well, maybe this will work. Oh, there we go. Good. So my talk today is about lung cancer screening, and lung cancer is near and dear to me. I've been very much involved in lung cancer in public education and community awareness and advocacy for many, many years. As Ashley mentioned, I think she mentioned that I was involved with the American Cancer Society. I was president of the Florida division of the American Cancer Society about 20 years ago in the year 2000. And I've been involved in public education and advocacy for cancer ever since coming to Jacksonville in 1988. And most of my involvement has been with the American Cancer Society. And when I first came to Jacksonville in the late 80s, early 90s, those of you who have been around that long remember the smell we had in Jacksonville with the paper plants, and there was that odor. And a lot of people felt that odor and that smell maybe was contributing to the high lung cancer incidence here in Jacksonville. And we, the American Cancer Society, and a collaborative of all the area hospitals at the time, did a large evaluation and research to determine why the lung cancer incidence in Jacksonville was as high as it was. And the postulate was that maybe it was the paper mills and those sort of things. And back in the early 90s, the lung cancer incidence in Jacksonville was highest in the nation as far as incidence per 100,000 people. And what we found out was that there's just a lot of smoking in Jacksonville. It really wasn't the paper plant, but just a lot of smoking in Jacksonville at that time. The prevalence of smoking in the early 90s was higher than other comparable sized cities. And those of you old enough to remember, you could smoke in restaurants, you could smoke in offices, you could smoke in hospitals. We had physicians at the hospitals that would smoke and nurses that would smoke on the floors in the wards. That's changed now. And in 2000, the American Cancer Society introduced an amendment to the Florida, a proposal for an amendment to the Florida Constitution, and that's an amendment for the Florida Clean Indoor Air Act, which was passed overwhelmingly by the citizens of Florida, and that now has helped us prohibit smoking in the workplace. And this was all under the guise of protecting employees, but really the truth is we want to minimize smoking prevalence, because smoking prevalence leads to lung cancer. And so we did this in early 2000, and because the citizens of Florida voted overwhelmingly in support of that, that's why you see now we have restaurants where you feel comfortable eating in because there's no smoke. All your workplaces now are smoke-free. It's very comfortable to go to work. That wasn't the way 25 years ago. So because of that, lung cancer has been very, very important to me. And I want to share with you today, I'm getting to my talk now, I want to share with you today a little bit about lung cancer screening and some of the new advances in lung cancer screening and what we know and what we can do to help diagnose lung cancer early and cure lung cancer. So here we go, next slide. So lung cancer is a very, very prevalent malignancy, and it's a very deadly malignancy. You all hear about breast cancer all the time and prostate cancer, and they have very high incidence. Amongst women, breast cancer is the most common cancer, and prostate cancer is the most common cancer in men, but it's not a cancer killer. If you look at cancer killers, the type of cancers that people die from, lung cancer is number one. By far, it's number one. And if you look at the numbers there, it's more than the first two combined. It's more than pancreas, breast, and prostate combined. It's a big number. It's 135,000 people are going to die of lung cancer this year, and the other numbers pale in comparison with that. Colorectal, pancreas, breast, prostate, they pale in comparison. Now, not to say that colorectal cancer, pancreas, breast cancer, and prostate cancer aren't important. These are very important, very prevalent cancers, and these are a major burden on society and a major burden on people. But lung cancer is very, very deadly. And what can we do to eliminate this deadliness? We could look for ways to eliminate lung cancer. And so here's the lung cancer death rate around Florida, and you can see that it varies quite a bit by county. That light blue is less than half the incidence, maybe a third the incidence of the very dark blue numbers there. And you see that the incidence of lung cancer, the death rate from lung cancer, is significantly higher in rural Florida, and it's lower in the more urban areas. And that's because typically in the more urban areas, people are more educated, people are more aware of tobacco and the issues with tobacco. And so we see that you see in South Florida, Miami-Dade, Broward, Beach County, the incidence is low. St. Johns County, the incidence is low. Around Tampa, it's low. Orlando, it's lower. But in the more rural areas, it gets higher because it's all because the prevalence of cigarette smoking, tobacco. Sadly, Duval County is up there pretty high, as you can see. It should be lower than that, but Duval County is pretty high, and up here where I am in Nassau County is very high. That's why we're in office up here. We're very busy up here with lung cancer. Sadly, because there's a lot we could do about that to decrease the death rate, and death rate is related to advanced diagnoses of lung cancer. So we looked for a way to find out how we could diagnose lung cancer early and maybe cure it. You know, breast cancer we found out in the 70s that mammography saves lives, and that with mammography, we can diagnose breast cancers when they're very small and when they're non-palpable. And the difference between having a palpable breast cancer, one you can feel, and one that you can't feel, the difference in survival is 70% when one's palpable versus 95% when you can't even feel it. So we try to extrapolate that and translate that to lung cancer. And we first looked years ago at chest x-rays. Nice simple thing, like a mammogram, right? Mammogram is relatively simple. You put the breast in an x-ray machine, take an x-ray of the mammogram, of the breast rather, and you get a mammogram. And that's how we diagnose breast cancer early. But chest x-rays, we tried to look at people and there was a large trial that was done that looked at using chest x-rays in average patients and then in high-risk patients. And we found out that chest x-rays had no influence on reducing cancer mortality. And the reason chest x-ray on lung cancer mortality, and the reason chest x-rays had no influence on reducing lung cancer mortality is because by the time you could see a tumor on chest x-ray, it was already too late. That the small tumors were not visible on chest x-ray. If you've ever seen a chest x-ray, it's very hard to read. And the only tumors we see in the lungs are ones that are already fairly advanced. Unlike a mammogram, where we're just looking at the breast and we're looking at it in very high resolution, we can see some small little calcifications, and those are usually related to early stage breast cancers. But chest x-rays have no value in diagnosing lung cancer early, have no value at reducing lung cancer death rates. We find lung cancer, but it's too late by that time. So between 2002 and 2010, there was this large trial called the National Lung Cancer Trial. And that compared using annual chest x-rays to what I have here, LDCT. What's LDCT? Low dose CAT scans, computerized tomography. CT, CAT scans. Low dose CAT scans. Why low dose? Because regular CAT scans deliver quite a lot of radiation. In fact, you get as much radiation in a CAT scan as you do flying cross country in an airplane. And we're concerned that radiation may help us find lung cancer early, but it could also lead to induction of other cancers such as breast cancer and other lung cancers. So anyway, using low dose CAT scans, we have a large data set of over 54,000 participants. And we found that we carried the chest x-ray. The chest x-ray, no reduction in mortality, like I already told you. But the CT scans had a 20% reduction in lung cancer mortality, meaning that those 27,000 people, because they were randomized, that had CAT scans on a regular basis, had 20% lower death rate from lung cancer than those that had annual chest x-rays. And the ones that had annual chest x-rays had no difference in lung cancer death rates than the general population. And so if that wasn't enough, that was an 8-year study. If that was enough, there's been 3 more randomized clinical trials that have also shown a reduction in lung cancer mortality, anywhere from 11 to 30%. So this just validates this large national lung cancer trial that we did between 2002 and 2010. I say we, it's not we, me, I wasn't involved with it, but just we as a medical entity doing that. And so what are the survival rates with lung cancer? So if lung cancer is caught early, in stage 1 cancer, you can see that it's about 80% survival rate, 1A, 1B, you say 1A, 1, 2, and 3. It's about 80% survival rate. Once you get to stage 2 cancer, that goes down quite a bit to about a 55% survival rate rather. And stage 3, where it's already involving lymph nodes, is only about 30% survival rate. And once it's in stage 4, meaning it's invading the other organs or spread throughout the body, the survival rate is very dismal, less than 10% live 5 years. So the key is to diagnose these cancers very early when they're small. What's stage 1? Stage 1 is a tumor that's less than 2 centimeters. 2 centimeters is about 3/4 of an inch. And so if we can find a lung cancer that's less than 3/4 of an inch, we have an 80% survival rate. If we can get one that's less than 3/8 of an inch, the survival rate's 92%. And so we're trying to find small lung cancers before they have a chance to spread to lymph nodes or, God forbid, other parts of the body. And these stage 1 cancers are the ones that are detectable by low-dose CT scan. They're not detectable by regular chest x-rays. These large cancers are the ones that are usually picked up by x-ray. So if you look at the 2 groups of patients, the ones that had x-rays versus the ones that had CAT scans, the CAT scan patients were detected typically in stage 1, and the x-ray patients were typically diagnosed either stage 3C, which is fairly advanced, or stage 4 disease. And you see the difference, the delta, if you will, in the survival rate is from 80 to 10, basically. So stage matters. Lung cancer screening finds 80% of lung cancers that are at early stage when it's more curable. So here's a, for instance, you can see in the upper left here, there's a chest x-ray and a CAT scan on the same patient. And it's really hard in that A with the arrow over there. If you see, I don't know if you see my cursor or not, but right here, it's very hard to discern that tumor that's sitting right there in the chest. If you look at this right here and compare it to the other side of the chest over here, it's not that dissimilar. It's different, but not that dissimilar. And when you're a radiologist looking at that, it's very hard to discern that. But you can see on the CAT scan, there's clearly a density right here. There's the patient's right lung, because we're looking at the x-ray, we're looking at them from the front like they're looking at us. And the CAT scan, the format's the same way, where we're looking at the lungs from below, as we cut the body in half and looking up from below. So you can see that's a good sized tumor there that you cannot pick up on a regular chest x-ray. Over on the right, we do the same sort of thing, that in that A box, you see the arrow pointing to some little shadow there. That shadow is hard to discern that there's something there, but down below it on this CAT scan, there's a CAT scan looking from the front. You can see that large tumor. So because it's close to what we call the mediastinum, the center of the chest, there's other structures that go through there, the esophagus, the vessels of the heart, and the heart are in there. The tumor gets kind of hidden behind there. You can't see it, but that's a big tumor. And on a lateral view from the side, again, with the arrow here, you can barely see that tumor, but on the CAT scan, you see there's a large tumor there. And that tumor there is not stage 1, by the way. That's stage 2 or 3 tumor that we have there. So CAT scans can detect nodules as small as 2 or 3 millimeters, and the person's chance of survival decreases significantly when the tumors are greater than 3 centimeters. Once you're 3 centimeters, you're already in stage 2 or stage 3 disease. So stage 1, less than 2 centimeters, and 2 or 3 millimeters is well less than that. These are ones that can be cured. And only CAT scan can find that, not chest x-ray. So we want some evidence-based data to change national guidelines, because if we're going to advocate for lung cancer screening, we need someone to pay for it. Medicare, commercial insurers, they don't want to pay for stuff if there's no evidence showing that it improves survival. We had a really difficult time back years ago to get mammography covered, and many of you may remember that some insurance companies wouldn't cover mammography. We had to go to the legislature and have the legislature put a mandate that insurance companies provide coverage for screening mammograms. We had the same challenges with colon cancer and colonoscopy, which also diagnoses colon cancer early and saves lives. So there is laws that mandate coverage for colonoscopies at the appropriate time frame. And so we did the same thing with CMS, which is the Centers for Medicare and Medicaid Services. And this national trial established the eligibility criteria that CMS has now adopted since 2014 in providing coverage for screening, low-dose screening CAT scans. And commercial insurers and providers rather are also covering screenings if the eligible criteria are met. Now, we've only been able to advocate to allow annual screenings for 5 years. And so we're still working on getting annual screenings for more than that, but I'll show you the criteria in a minute. But this is a big win, and we're still advocating for even more enhanced coverage of screenings. So what is the criteria? A 30-pack history of smoking, age 55 to 74 years old, and still smoking or quit within 15 years. Now, what do I mean by 30-pack year of smoking? So when we look at a smoker, there's this occasional smoker who, it used to be the woman. I don't mean to sound like a sexist, but it'd be a woman who'd smoke 1 or 2 cigarettes a day just to be social with her friends, versus the guy who smokes 3 packs a day, right? And so they're both not smokers. They're both smokers, but they're not the same level of smoking. And someone that smokes 1 or 2 cigarettes a day doesn't really have doesn't have the same increased risk of lung cancer as someone that smokes 2 or 3 packs a day. So we created this thing called pack years. So if you smoke 1 pack a day for 30 years, that's 30 pack years of smoking. If you smoke half a pack a day for 60 years, that would be the same thing. Or 2 packs a day for 15 years, that's a 30-pack history. So we have some people that smoke 3 packs a day. I'm sure you have an aunt or uncle that smoke, or you maybe know somebody that smoked at that level. So 3 packs a day for 10 years is 30-pack history. And it's at that point where you have a significant enough history of smoking that puts you at a significantly increased risk of lung cancer that would put you in the proper criteria to do screening, CT scan, a low dose CT scan for screening of lung cancer. And so those are the criteria. So we have a lot of adults who've tried to quit. And so this is an interesting number as well. So here's the data for the state of Florida about the adults who've tried to quit at least once in the past year. And you can see, again, that it's very variable around the state. And you can see it's variable in our region. But these adult current smokers, about 2/3 in the counties around us, is fairly high. The number of people who have tried to quit is very, very hard to quit smoking. And so 2 efforts. One, let's encourage smoking cessation. Few efforts. One, facilitate smoking cessation. Number 2, advocate for less availability of tobacco, clean indoor airspace, taxation on tobacco products, those sort of things. And number 3, advocate for lung cancer screening with low-dose CT. So I just was mentioning that what we want is to cure lung cancer, and to do that, we need to get people screened, like we have women doing mammography. We have mammography guidelines, and about 2/3 or 70% of women are getting their mammograms as per guidelines, annual mammograms over the age of 40. But we have screening guidelines for lung cancer. And look at these numbers, it's appalling. Only nationally, less than 5% of people who are eligible to be screened, who have insurance coverage for this, either through Medicare or through commercial insurance, are only less than 5% are getting screened. That means over 95% are not. In Florida, it's even worse. We're below the national rate, and it's just appalling. 98% of people who should be screened are not being screened in Florida. Why? I don't know. Why aren't taking advantage of them? I think the answer is because we still need to do more education with primary care physicians, and we need to do more education to the general public. Many people don't know about the guidelines, and so it's our job as a medical community, and you guys can help me as business community leaders to inform those that you influence to be advocates for their health. And that's why I'm speaking to you all, the JAX Chamber Health Board. So there's a Florida Cancer Plan. The Florida Cancer Plan is a development of the Florida Department of Health. As you know, I'm on the Board of Medicine, which is a subgroup of the Department of Health. And so the Department of Health has a Florida Cancer Plan that do in collaboration with other stakeholders. These stakeholders are the American Lung Association, American Cancer Society. There's a number of Fresh Start Florida. There's lots of entities around Florida that are part of this collaborative. And the plan is, between now and the next 5 years, is to educate the public about who is at risk for developing lung cancer and who should undergo screenings. Also to educate the public about early signs and symptoms of lung cancer, and also help them know where to seek screening. And also, we want to incorporate lung cancer screening recommendations into our tobacco control messaging. So you've seen a lot of tobacco control messaging. I'm sure you've seen commercials on TV. Some of them are pretty gory. In that same messaging, we also want to integrate into that messaging lung cancer screening. And also, we want to educate primary care providers. People are influenced by their primary care physician. And we found out with mammography, the reason women were not getting mammograms when they should back in the early 90s was that because their doctor didn't tell them to. And it's because we didn't, and so what we did was we moved forward in educating primary care physicians and primary care practices, primary care nurse practitioners and physician's assistants about the importance of lung cancer screening. And we would support them in developing and implementing system changes in there to improve lung cancer screening. And not just the direct primary care providers, but also health systems like Baptist or St. Vincent's or Memorial, whatever health system there is that has within their enterprise a primary care network or the infrastructure to do these low-dose CAT scans, because any entity that provides CAT scanning for diagnostic purposes, for monitoring purposes, can also do low-dose CT scans for lung cancer screening. So I hope I didn't go too long. I think I might have. So I'm available now for any questions. Was it on the chat? No.
Hey, Dr. Ackerman, this is Josh Stewart. I just had a question. Do you have, I guess I've seen a lot of these chest x-rays from folks who are survivors of COVID. Have you heard, or do you, like, what do you suspect, or what's the research on potential impacts to lung cancer because of COVID and things like that, or is it just too soon to know about it?
Well, the short answer is yes, too soon to know. But the lung cancer, these patients, a lot of patients that have COVID, and so, certainly in my practice, a lot of my patients get CAT scans for whatever kind of cancer they have. They might be doing a CAT scan, and I have a significant number of patients that have had COVID. And whoa, you look at these CAT scans and like, holy cow, what happened? There's lots of nodules in the lungs, in the periphery of the lungs. You get these all sorts of nodularity. And they're kind of spooky looking CAT scans. When you look at them, you think sometimes it almost looks like lung cancer, but it's not. And you can tell by the distribution, it's probably not. But the concern is that this could become cancer in the future. We know that certain lung cancers begin in scars. And we see people who have had pneumonia, who have had some scarring in the lung from something. I don't mean that scarring from a knife, or I don't mean a physical scarring from an object, but scarring from a bad pneumonia or bad infection of some sort, or from tuberculosis. You'll see scarring in the lungs. In those scars, they can eventually develop cancers, and we see that, and we monitor them closely. And I would think in COVID, that sort of scarring might put them at higher risk.
Dr. Ackerman, you mentioned non-small cell lung cancer. I'm curious what the treatment options are for those, if it has spread to lymph nodes or not to lymph nodes. What are the treatments for that?
Thank you, Heather. That's a very, very good question. So first, let me talk about the treatments where it hasn't spread. So we're doing these screenings to find cancers that are small before they spread. And in those cases, the cure rate's very high. And the treatments are usually twofold for these small, less than 2 centimeter tumors. One, surgical resection. A small surgical resection doesn't need to be extensive lung cancer surgery. Lung cancer surgery is not easy to do. So it's a resection of that tumor or removing that lobe of the lung. The second treatment is what we call stereotactic ablative radiation therapy. This is one of the things that I do. And we use radiation in a very highly focused manner to irradiate that tumor. It's typically 5 treatments, and the cure rate is over 90% with just 5 radiation treatments, and it's not a non-operable sort of treatment. So it's, to put the patient to sleep, and these patients tend to be older. If, the risk factors of this 30 FACR thing, so many patients have already compromised lungs. So by doing this very focal radiation, you're not damaging very little lung tissue, and so it's a good option as well. Heather's question was, what are your options once it's spread to lymph nodes and other parts of the body? So there's really 2 more stages I want to talk about. One is where we have what we call regional disease, and this is typically stage 2 or stage 3 cancer cases, where it's involving lymph nodes in the chest, where it's in the lung and involving lymph nodes in the chest, but not anywhere else in the body. Those patients are typically treated with chemotherapy and radiation therapy, usually given concurrently, but sometimes sequentially. So concurrent means both at the same time. Sequentially means you may do the chemo first, then the radiation afterwards. And what we have found in those patients, that some of these newer targeted therapies, these immunotherapies that you might have heard of, you see a lot of commercials on TV for drugs called Ablative or Keytruda, those sort of drugs, that these immunotherapies act as an adjunct to the conventional chemotherapy and radiation therapy and provide targeted treatment and enhance the cure rate. Once patients have tumors that have gone beyond those lymph nodes to other parts of the body, to bones or the adrenal glands or the liver, brain, those sort of places, then those patients are typically treated with chemotherapy. But now we more and more, and that used to be a death sentence. You would hear someone with non-small cell lung cancer in other parts of the body Historically, that's a death sentence. But now with these really cool immunotherapies, these really cool targeted therapies, these patients can be treated. And I have patients now that have been going on 4 or 5 years, because these drugs have only been around that long, who have no evidence of disease that 5, 10 years ago would have been dead in 6 months. And so some of these cool, and they're very expensive, but they're very cool and very useful targeted therapies, but they're not for every lung cancer patient. What we do is we take the lung cancer tissue and we look at the genetic screw up in it, we look at certain markers in the genes and and how the RNA and DNA are all screwed up. And we look at certain things in there, and that tells us which patients would respond or might respond to these drugs. It's something called PD-L1. I don't want to get into it too technically, but not. I don't want you to think that these drugs are a total panacea, because they're not really for everybody. They're only for the certain subset of patients that have these genomic screw-ups in them. Thank you, Heather.
Thank you.
Okay, guys, thank you very much, Dr. Ackerman and the team at Ackerman Cancer Center. That was very informative. And again, thank you for your time and coming to talk to us today and everything that you're doing for the community in Jacksonville. So really appreciate it. We're going to spend now about maybe